Think forward. Think Research Channel.
Hopefully I can provide a little information that'll keep you guys running and staying active. So I've been running about 20 years and doing triathlons about 15 years. And I had a lot of these injuries myself, so I think hopefully I can have a little insight on that. So my first marathon I was training for, it was about 16 years ago, and I'd never run over 13 miles, and so I was really naive that way. And I was trying to qualify for Boston, so I was really moving along there with my partner, and about the 15th mile, I was like, gosh, my feet really are killing me, and I just couldn't figure out why. And so I finished the finish line, and I just had to rip off my shoes and socks, and I had like 4 bloody toenails, and I had to go to the podiatry tent right then and have them drained. And so it was a rude awakening. So hopefully that won't happen to you guys. So the first condition is plantar fasciitis, and that's probably, you guys are all probably familiar with that. It's like the common cold of foot injuries. It's very, very common, and basically it's just an inflammation of the connective tissue that expands from the heel bone to the ball of the foot. And basically it's really commonly injured because it's where we strike the foot initially. And so common symptoms of that are pain in the morning. It feels like somebody's stabbing you with an ice pick the first step out of bed in the morning. Or you can have pain at the end of the day. But there's varying degrees of pain and symptoms. The reason it hurts so bad in the morning is because what happens is the tissue gets inflamed, and it actually, you get little tears in the tissue, and it bleeds and scars down, and then it gets really thick, and it doesn't, that first step out of bed in the morning really pulls on the fascia, and once it's stretched out, it feels a lot better, but initially it can be very uncomfortable. So, but then you can also have pain right behind the ball of the foot because it inserts right into the metatarsals where the ball of the foot is. So you can have varying degrees of pain all along that area. So how do you treat it? Well, initially, icing and stretching are key because we're going to try to get the flexibility back and get the inflammation out of the tissue. So non-weight-bearing exercise is really critical. I think that if you continue to run or walk or hike, it's just going to prolong your misery. And so I know runners don't like to take time off, but you can still work out. Just you have to do it smart so you don't continue to injure it. So orthotics are also helpful. Now those are more helpful if you have really significant biomechanical problems, like if you're super flat-footed or if it's super high arch, what we call, if you're really flat-footed, you're what we call pronated. And what happens with that is your foot's basically hypermobile. It moves around a lot, and then your plantar fascia actually has an increased pull on it when you weight bear. So those people are prone to injury, so orthotics are really helpful for that. Physical therapy is helpful as well. I advocate your own physical therapy initially with icing and stretching. A great way to ice is freeze a water bottle and roll that along your foot. That really helps, I think, especially after activity. And then stretching is key. I usually tell people to grab the end of their toes and pull their foot back and hold it for 30 seconds before they get out of bed. If they do that like 3 times, when they hit the floor, you're going to be a lot more comfortable. And that goes also if you've been sitting in a movie or in a car for a long ride, you should stretch before you get out. Night splints, that's that's what night splints are trying to accomplish. They're trying to keep the foot flexed so the plantar fascia can keep its range of motion, so you don't have that brutal pain in the morning. And shoes are also important. If you wear, I see a lot of plantar fasciitis in the summer months because people go barefoot, or they wear flip-flops or really flat shoes, and there's just not a lot of support. So you got to look at all your shoes. And then cortisone injections, they are really helpful to break the pain cycle. I don't use them a lot, but if there is a really bad case, you can put a little cortisone in there, and it's just a really potent anti-inflammatory. And taking non-steroidal anti-inflammatory drugs is great, like Advil or Aleve or Celebrex. But if you have a really acute pain, the injection can really break that pain cycle and make you a lot more comfortable. So the common theme here is you have to be proactive. You cannot just rely on one thing that will get you back on the streets running. I think you need to combine all the things. This is an example of a Lodi taping. It kind of simulates what an orthotic would do. So some people think it actually helps more than orthotics do because it's right on the tissue. So if you have a race the next morning and you have a really bum foot, you can get some athletic tape, and it's pretty easy to do. You just put 3 straps around the side of the foot and about 6 straps on the bottom. And it basically protects the plantar fascia and gives it a little bit more support. So that's another picture of the straps going around the side. And these are some molds of orthotics. How we make orthotics is we take a non-weight-bearing cast of your foot and we put it in the neutral position. So when we have the orthotic made, it's going to put your foot neutral, so the tissue won't get overstretched. And that's super helpful if you have a really pronated foot. These are some cam walkers. I use these a lot for all types of injuries, metatarsal stress fractures, but they're also great as night splints, or if you have a really bad case of plantar fasciitis or heel pain, because it has a rocker bottom. It's like a circle on the bottom, so that just facilitates walking, and then you can wear it at night, so it will keep your foot at 90 degrees. So the next thing is Achilles tendonitis. This is super common in runners. I've had this myself, and it's just because there's just so much motion going down. Every step we're using this tendon, and it's really has a very poor blood supply, not like muscle or bone, so tendons tend to not heal as quickly. And classically, you get like a fusiform swelling. The tissue just kind of bulges out right about 5 centimeters superior to its insertion into the heel bone or calcaneus. And this area is classically called the watershed area because it's got a very poorly vascularized area, and so it's really susceptible to injury. So this is just a photograph of that. It's hard to see, but if you look a little bit above the heel bone, you can see it kind of bulge out right there. So how do you treat it? Well, you got to rest it, but that doesn't mean you just sit on the couch with a clicker. You can run in the pool, you can bike ride, you can swim, but the key is to not keep using it. If you continue to run, especially hike or run hills, it just won't get better. And so icing is really helpful. The thing about this is you got to be proactive. I think icing and physical therapy type modalities are great, but I really use a lot of heel lifts because they can rest the tendon while you're still using it. So you can put them in your running shoes and it will elevate your heel, and that will rest the tendon even while you're walking around. So physical therapy with ultrasound is helpful, and just appropriate shoes. I think for women it's really helpful to wear a slightly elevated heel, like a clog, for example. That's a great shoe, or a mule type shoe that has like a 2-inch heel, because that will really elevate it. This is the slide just going over some heel lifts on the side, on the right here. That's a 9mm heel lift I use in my office a lot, and I like it because you can adjust it. You can tear off the bottom of it, so it's you can kind of customize it, because 9mm is pretty high, so that you can pop out of your shoe, but that's why it's pretty helpful. And it's leather on the top and rubber on the bottom. Medial tibial stress syndrome, that is pretty common as well. I see this a lot in people that have really pronated feet, and it's really common training error, or after people start running a lot of hills. The tissue on the inside of the tibia gets really inflamed, and it can be really uncomfortable. This can lead to actual stress fractures or occult fractures. I had a patient that we did a bone scan on, and she definitely had a stress fracture, and it's really hard to get over. It takes time, but how do we get over it? Well, if you're pronated, you've really got to use orthotics. Resting, again, that's key. But again, I think that's one reason I started doing triathlons, because I'd get injured and I would want to continue to work out. So I think cross-training is really helpful, and there's just more and more information out there that the benefits of cross-training, because we are using different muscle groups and so forth, so we're not going to tend to get an overuse injury. So ice, again, that's super helpful. Stretching, physical therapy. I use a lot of physical therapy because the physical therapist can really assess your needs and how flexible you are, and they can give you like a home program in which to do. So you can, they'll just give you like a homework assignment and with all the stretching that you can do, and it's really helpful that way. Orthotics I find are really helpful, and new running shoes. I find that people come into my office in shoes that are really worn, and running shoes especially, you can't really tell when they're worn out when you're looking at them at the upper or the sole. It's inside the shoe, the midsole, that starts to break down. So I'm a real advocate of replacing shoes. I spend a small fortune on shoes myself, and I replace mine about every 250 to 300 miles because I start to feel more pain in my knees, and so that is really key. And then you've got to be careful about your training. I think running on flatter surfaces when you have this syndrome, is really important. Like a soft track is a lot easier on your shins than doing the dish. Morton's neuroma. This is another real common injury in the ball of the foot. I see this a lot in runners and active folks, and especially in women, because women tend to wear more tight, high-heeled type shoes. But basically, it's a perineural fibrosis, or inflammation around the nerve. The nerve develops scar tissue as it gets pinched between the metatarsals. The metatarsals don't give us a lot of room, and they're dumbbell-shaped in the ball, so there's a real tight space between the third and fourth metatarsals, and the nerve is anatomically usually bigger in that spot, so it's really susceptible to injury. So typically you're going to get sharp pain between those third and fourth metatarsals. I see it a lot between the second and third as well. You get like pins and needles type sensation. It can radiate into your toes. You can have a clicking sensation when you're moving your foot around. And people commonly describe it as, gosh, I just feel like something's in my shoe, like a piece of gum or something. And so it's those, when people come in with those symptoms, it's pretty easy to diagnose. So how do you treat it? Well, this is another thing that requires usual aggressive treatment. Running shoes are key. Not everybody's foot is the same, and so you really need to go to a running store that knows a little bit about feet. Metatarsal pads it's another great thing to help with this. It's in the weight-bearing part of your foot, so it's really hard to just off weight, so we have to be creative with metatarsal pads, and those are really helpful. Cortisone injections are also helpful because if you treat this initially, you can really shrink down that swelling, and you may only need to give them one shot, and they're right back on the road. If it's been around a little bit longer, then I tend to use a dehydrated alcohol injection, And I've been using this a lot in the last 2 years, and it's really cut down on the neuromas I have to excise. And with runners or all active folks want to avoid surgery at all costs. And so this has been a great new treatment that I've been using. It's a little uncomfortable, but it really does work. Orthotics, again, if they're pronated, again, when you're pronated, your foot's hypermobile. It moves around a lot. And so that causes the metatarsals to move around a lot, and that can easily irritate the nerve between the metatarsals. So orthotics are pretty important. This is an example of a metatarsal pad. I use a lot of these inserts, Superfeet. If you're mildly pronated, I think that's a great product. Again, I'm not on their payroll, but I use it a lot, and a lot of the running stores carry these. And the metatarsal pad looks like it's almost in the arch, but it needs to be behind the metatarsals to kind of fan the metatarsals when you bear weight. And it feels a little funky at first, but it's really, really helpful. Stress fractures. Basically, this is an incomplete fracture due to excessive or cumulative trauma running. We used to call them, you also can call them march fractures. I see a lot in recruits in the military, just from all the marching and activity. And the bone basically starts to fatigue, so it's kind of hard to diagnose initially because, it's a fracture. I could just take an X-ray and we'll see it. But the bone is it's sensitive, and so it's hard to diagnose almost until after it's starting to heal. So what you'll see on the X-ray is nothing until 2 to 4 weeks, and then you'll see this little cloud-like appearance around the bone, and that basically is the healed fracture. And typically you're going to have pain on this really specific area of the top of your foot. I see it a lot in the second or third metatarsal and in the fourth, not so much the first or the fifth. And usually it's a crescendo type pain. It kind of gradually comes on. And again, it's really common in people that are doing training errors too much too soon, or their shoes starting to wear out, or just kind of a combination of things. It's also common in folks that are obese or overweight, and then not wearing appropriate shoes that are supportive. So how do you treat it? Well, again, rest. That's important. It takes usually 4 to 6 weeks for the bone to heal. I don't think you need to be non-weight bearing. I put people in a post-op shoe, which is just a stiff-soled shoe, or one of those cam walkers. And then again, I think if you replace your running shoes frequently and you try to mix it up, not maybe run every single day and maybe swim and do some other things, I think you shouldn't probably run into this. I like the lower leg cam walker for the stress fractures because that big guy is pretty heavy and bulky. Sesamoid injuries are another common injury in the ball of the foot. I had this when I was living in San Francisco, running a lot of hills, and boy, does it hurt. It really hurts right underneath the ball of the foot, right up behind the big toe joint. And basically the sesamoids are these little accessory bones that are within a tendon, the flexor hallucis brevis tendon. And they're basically the ball bearings of the foot right there, and they're commonly injured, and they help they act as a pulley system for the toe to flex the big toe down. So there's two injuries. You could just have sesamoiditis, and that's just basically an inflammation around the sesamoid bones due to overuse or inappropriate shoes, or you could have a real fracture. Those are sometimes hard to diagnose because the sesamoid can come in two pieces in what we call bipartite. So you'll take an X-ray and you'll see these two little sesamoid bones that look like there's a fracture between them. But what I do is I take another film of the other foot to compare, and usually it's bilateral. They'll have bipartite sesamoids, which are in two pieces. And then you can take a special view that usually will show a kind of a really jagged edge, and that's usually pretty indicative of the fracture. Some of them are just, you could just see, fractured right through, and some of them are even a comminuted fracture where it's in a couple pieces. And it's classic. You just push under the ball of the foot and they jump out of the chair. It really hurts. So how do you treat it? Again, ice, relative rest. I think orthotics are really helpful for this. And if it's really bad, to break the pain cycle, I inject a little cortisone in there. The cam walker is a great device because, again, it's a great way to off-weight the area. It just distributes the weight more evenly throughout the foot. It facilitates your walking, and it's really can calm it down. Anti-inflammatories, Aleve, Advil is great. Physical therapy, ultrasound, I use a lot of that. Ionophoresis. And then I've had to excise a few of these that they just don't heal. They do kind of go on to non-unions, or they just don't heal. Again, I think it's something to do with the blood supply and just that it's just an area of a lot of pressure. There's just so much weight going through there, and we're just pushing off that area with every step. So this is an example of metatarsal, actually a dancer's pad, the super feet in the middle. You can see how it's kind of cut around, and that, again, you can incorporate that into a custom orthotic, but initially I like to put this on a super feet, and it's just a felt adhesive pad, and it really works well to off-weight it. And then combining the other things like the Advil and resting it, I think it's fairly easily treated if you treat it soon. The three probably biggest things in the ball of the foot are the metatarsal bursitis or metatarsalgia, the Morton's neuroma, and then the sesamoid injuries. This I tend to see a lot under the ball of the foot, specifically under the second metatarsal, I think is the most common because there's just a lot of load right through there. And again, it's due to just a high pressure point. There's just a lot of motion going through there, and it's frequently injured. So what happens with this is we have these little fluid-filled sacs called bursa that pad underneath bony prominences. And again, the bursa in this region can get really inflamed and cause a lot of discomfort. And again, it's pretty easily diagnosed. You can just push on the ball of your foot, and you'll really feel it. And again, the sesamoid pad, the metatarsal pad is really helpful for this. It feels a little bit weird at first, but it really can off-weight that area. And again, I think a lot of us tend to treat this ourselves, and sometimes the foot, you kind of blow it off. It's just a foot, it's not important. I'll just get better. I'll just take some Advil. But some of these things can be really easily treated if you get appropriate treatment soon. And so and a lot of these things can be avoided by just appropriate shoes and replacing our shoes. So I just can't stress that enough. And so don't be afraid to go to a podiatrist and have it evaluated, because really it can make a big difference. The etiologies are pretty common. I just went over that. Old running shoes, a lot of excessive heel running, because again, when you're running uphill, you're on the ball of the foot a lot, and that can really cause this. Again, running downhill as well, you're really causing a lot of jarring there. And then as you get older, the fat pad can start to atrophy, or actually it can move to the front part of the foot. So it doesn't really adequately pad the metatarsals. So you're prone to that if your feet are really bony, or if your fat pad is atrophied. And then if you have a biomechanical problem like really long metatarsal, or one that's kind of plantar flexed or pushing down, that will hit more of a load and can be more susceptible to injury. A lot of times also, this can be misconstrued as just having a corn. You can get if you have a plantar flex metatarsal, or one that's a little bit longer, you can get a lot of callus formation. And I see a lot of this that can really be uncomfortable. And it's frequently misdiagnosed as a wart. But if you look on the ball of your foot, that's a weight-bearing part of your foot. And typically warts aren't all the time going to be in that area. And warts are also easily diagnosed. They usually have these little red dots in the center, and those are little thrombosed capillaries that feed the wart. And if you have more of a corn, it's a clear kind of translucent color. And so sometimes if you just have that trimmed down, you're fine and ready to go. So again, how do we treat it? Ice, anti-inflammatories. I think putting another pad in, like a superfeed or a sorbothane, is helpful. A lot of women in their high-heeled shoes that doesn't have a lot of padding in there, so sometimes it's helpful to put a little pad in there in your just regular shoes. Metatarsal pads, orthotics. I make a lot of custom orthotics with a metatarsal pad incorporated, and that really does help a lot. I see a lot of this in really high arch feet. So when your foot is a really high arch, you're really going to hit the ball of the foot. And just in general, high arch feet tend to be feet that need a little bit more cushioning. They're a little bit less, they have a little bit less shock absorbing capability. So you need a more cushioned running shoe, and you're more prone to these metatarsal bursitis type symptoms. Black toe. So again, this is pretty common in runners. Basically, we call it a subungual hematoma. It's just a blood blister that forms underneath the nail, and it's caused usually from inappropriately fitting shoes or a lot of downhill running. But the blood pools underneath the nail bed between the nail plate and the nail bed, and it can be exquisitely painful because, again, that shouldn't be there. There's not a lot of space underneath the toenail to accommodate that, and it can be like a boil. And so, believe me, doesn't feel very good. So this isn't a very good photograph of this. This is also, the patient has fungus in their toenail. She suffered subungual hematoma, and then she subsequently got a fungal nail infection. That's why it's a little bit yellow. And just with fungus, a lot of runners will have fungal nails or traumatized nails. And that's because, again, we're typically active folks, and we're sweating in our shoes, and our toenails are getting traumatized. And so when they're traumatized, it's an easy way for the fungus to get in. So it's a portal of entry. And so what will happen is the nail will typically start to lift off the nail bed, and it can be really get really thick and really uncomfortable, and then the cycle just continues. It just gets bruised, it gets thickened, and then it comes off. So, and this is another example of a guy that went hiking, and you can see his big toe and his second toe there are both black. So again, it's caused by running downhill and inappropriately fitting shoes. Again, I learned the hard way from this, but typically I usually recommend getting your running shoes a little bit longer and buying your shoes at the end of the day. I think that's key, or after a run. And I typically just get maybe a half of the width of my thumb at the end of the longest toe, and that usually will accommodate for any kind of swelling that's going to go on in your foot, because your feet obviously swell when we're active and running. So how do you treat it? Well, when it's acute, it can be really uncomfortable. So how do we get rid of it? Well, this sounds a little bit brutal, but I find that sometimes if it's really big, you'll actually see a bulge of the blood underneath the nail, so the nail will actually lift off a little bit. So it's pretty easily poked with a little needle, or you can even cut a little bit of the nail and tissue with a nail clipper. It's best if it's pretty uncomfortable, to see a podiatrist, that they could numb it up and have more of a sterile technique. How they did it for me is I went to the podiatry tent, and they used a little needle off a syringe, and they just burred a little hole in the top of the nail, and it took a long time, and it didn't feel very good, but it was instant relief after they did that. So I think that's about it. I'll welcome any questions if I didn't go over. Yeah. The question was Achilles tendonitis, and I didn't mention stretching, and he was wondering about that. You're right. I should have mentioned that. I do recommend stretching, but sometimes I find that the patient will stretch too much in their quest to get the tendon back to its normal range of motion. And so I think stretching is important, and the common one that I recommend is, pushing up against the wall with your leg back, and doing that several times a day, especially I think before exercising. But I think you can kind of go overboard with that. So I should have mentioned that, but I kind of didn't want to get too much into it because I think people they've overdone it. And even sometimes when I send people for physical therapy for that, they'll actually aggravate the tendon because they're trying to strengthen it and get it back. And so that's a good question, though. Yeah. Yeah, the question was, is massage helpful for the treatment in addition to stretching for Achilles tendonitis? And yes, again, I forgot to mention that deep tissue massage is great because, again, that tendon has a poor blood supply. And so people don't like to do it because it hurts, but I think it's great because, again, that's going to bring in blood supply and break up the scar tissue there and get it back to normal. So, yes, that's very key. The question was icing, how long, and is there a protocol for that? Yes, usually I recommend icing for no more than 10 minutes. I think 10 to 15 minutes is plenty. And if you can do it several times a day, that's the best. I mean, especially for plantar fasciitis and Achilles tendonitis, if you can do it 3 to 4 times a day, that would be great, and especially after activity. So, the question was, she got a black toenail and then subsequently got fungus in the toenail. Well, the real way to treat that would be with an oral antifungal medicine, and people get a little bit leery of this. I prescribe it a lot. It's advertised a lot on television. Lamisil is one of the ones that advertises a lot, and it's there are risks involved. It could cause potential liver side effects, but what I do is I take liver function tests and a CBC before I prescribe the medicine, and then again at 6 weeks after you've been taking the medicine. And I haven't really had anybody that had a significant problem. Now, you also have to worry about if you're taking other medicine that can be taxing on your liver, like Lipitor or any kind of anti-cholesterol medicine. Sometimes your physician won't want to prescribe both. I myself have not seen a problem with that. And you can also pulse it. If you only have one nail involved, you can take it 1 week per month, and then you don't really have a lot of risk of side effects. But there's only one agent that can really help topically, and that's this medicine called Penlac, and it's a nail lacquer that you apply to the nail, kind of like just toenail polish. But again, that requires a lot of maintenance on your part. You have to keep the nail cut short and filed smooth, and I find it takes forever. So I don't know, if you're diligent, I guess, and patient, it will work. So, is it common to have plantar fasciitis for a year, even if you're seeking treatment from a podiatrist and you're diligent about the icing and so forth? I wouldn't say it's common, but I do see it enough. And I kind of almost treat plantar fasciitis as a chronic condition sometimes, kind of like diabetes or high blood pressure, and being like your orthotics are the way to keep you kind of going without an acute symptom, but it can develop into kind of a chronic condition. There's one treatment I didn't really mention. It's called extracorporeal shockwave therapy, and it's really common in Europe, and it's getting more common here in the States. Basically, it's the same technology that they use for breaking up kidney stones, urologists, and they use an ultrasound or a shock wave, and what it does is it creates micro trauma, or what we call controlled damage, and that brings in new fibroblast or blood supply so it can heal. So that might be something that you may try to mention to. It's the one problem with that is that a lot of the insurance companies are calling it experimental, so they're not covering for that. But I think if you've had it for longer than 6 months, I think you can get it approved. And basically, you go in and have this procedure done. I think it takes about 45 minutes. It's a little bit uncomfortable, so sometimes they'll inject a local, and then you'll have maybe a little bit of a wrapping or a dressing, maybe a cam walker on your foot, and then you typically you're feeling better in about 6 weeks. So that's something to consider. The question is, when is it more appropriate to stretch to prevent plantar fasciitis, before or after running, or both? And I think it's both. I think that's best. One other thing I've found that helps with plantar fasciitis and a lot of these problems is, as we get older, we're less flexible. So I've been advocating a lot of yoga for my patients because, again, yoga is something that most people can do, and there's all levels with it, and that's another way to stretch the whole body. And I find that a lot of the stretches are helpful for plantar fasciitis, because I find that when you're prone to plantar fasciitis, a lot of times you have a lot of tightness in your Achilles or hamstrings or calf muscles, and so that can help prevent that from occurring. So Achilles tendonitis and plantar fasciitis are pretty linked, and so people that have what we call an equinus or tight heel cords tend to get more problems with plantar fasciitis. So I think it's both, and then you might want to consider yoga or something like that. The question was about socks and the different materials. I think that the socks that are what they call double layer or acrylic socks are best for running because A, they prevent blisters, and B, they're thinner usually, and they wick the perspiration away, so it will prevent blisters from forming. So there's a couple brands like Defeat, it's D-E-F-E-E-T is one that I use a lot. Wright, W-R-I-G-H-T is another sock that's pretty popular. People also like thicker socks sometimes too, like Thorlo. I find those to be a little bit thicker, but one benefit of those is they're a little bit more padded. So some people that have more pain in the ball of the foot, it does kind of give you a layer of extra padding. So the question was synthetics. I find that material isn't a problem. I find it's the newer socks are usually a combination. So Cool Max is a material that's commonly used in a lot of those, and that is a synthetic product, I believe. So the question was how often or how long before you should replace your orthotics. That's a good question. Typically, it could be anywhere from 3 to 7 years. It just kind of depends on the wear of the orthotic, and so some people are a little bit harder on the orthotic, but most orthotics that are made out of a polypropylene material, it's kind of a harder plastic, will really hold up well. I find that the top cover or bottom cover tends to get worn off with little stones and so forth, and so I replace those probably every year. Just because they can make the orthotic feel better, but I don't advocate people, wearing their orthotics for 10 or 20 years. I've had people that do that, but because I think your foot does change, and as we get older, your foot typically gets wider and longer, and you'll notice you'll need bigger and bigger shoes. So I do think it's wise to maybe have it evaluated maybe every 3 to 4 years. Okay, the question was, how often do you replace orthotics in adolescents? And that's tricky because they're obviously growing, so you want to make sure that it's fitting appropriately. Usually the orthotic, the hard material that controls the foot's going to end right at the first metatarsal, so right kind of behind the big toe joint. So I find if it's like in the mid-arch, obviously it should be replaced, but if it's around the first metatarsal and not really in the mid-arch region, and it conforms fairly anatomically to the foot when you put the orthotic up there and it's not worn out, then I think it can last for several years. So the one question was, she gets an accumulation of some skin between the third and fourth metatarsals. Would you recommend seeing a podiatrist to have that shaved off? And yes, it's pretty hard to get it trimmed down with a pumice stone or a callus file or an emery board. And a lot of times you'll have a little seed or a little kind of a root to the callus, what we call a keratoma. It would be translucent, and that's nearly impossible to get rid of without going in there with a 15 blade. And you don't draw blood, you just kind of pare out the core, and it's instant relief. So yeah, I think that's definitely. And then your second question is? So the question was, she gets some pain or hotness in the ball of her foot in that same area, and or the orthotic won't really work in the shoe. Yeah, with biking, again, we're on the ball of our foot there. So I do make specific orthotics for biking, and they're a little bit different. I put a little bit of a post on the forefoot and to kind of actually pronate the foot a little bit, and that actually helps with getting hotness. I think the hotness could be a little bit of a nerve entrapment, and you may be having that as well as just the corn. I think it's probably a little bit, you may be getting a little bit of an aroma there, or entrapment of a nerve, and so that could be causing the heat and problem with that. But I've found even trying superfeet in cycling shoes helps. Also, sometimes adjusting the cleat on your pedal, moving it slightly forward or back or somewhere, or trying a different shoe can help. So that's a tough one. A lot of people complain of their toes going to sleep when they cycle, and that was more common when they didn't have the pedals that they have now, but I still have that problem off and on, and I think it's definitely a pressure thing. I think it's hitting the nerve or something causing a little irritation there. The question was, how do you determine the appropriate running shoe when you go to these fancy running stores? So one thing that happens sometimes is these guys are a little bit too aggressive in treating your biomechanical problems. They'll say, okay, you're pronated, we got to put you in a motion control shoe, and not everybody can tolerate that, and I think sometimes you're overcorrected. So that's a problem. One thing that I've found is a lot of times the shoe companies will keep changing the shoes, and so you'll like a shoe and then they'll change it the next year. So I tend to tell people to buy maybe 2 or 3 pairs of the shoe they like and hold on to it, because it can really be kind of a hassle to buy a shoe. That's a difficult problem. Usually if they're a reputable shoe store, they're going to want you to come back and tell people about them. So typically they'll work with you and help you. So sometimes it's even helpful to go to a podiatrist and just have them look at your feet and so forth. Typically, though, flatter feet tend to be hypermobile feet, so they'll want to put you in more of a stability shoe. Higher arched feet tend to need more cushioning. But there's a lot of different combination lasts now on the running shoes, and so I find a lot of good things with Asics, and Mizuno is another good shoe that's fairly popular. So the question was, is there a place where you can buy flat
rubber-soled sneakers? That is a good question. Well, there's a lot of retro shoes out there nowadays, like all these Pumas and Adidas when I was a little guy that are coming back in style. So I saw a lot of those at just at the department stores like Nordstrom's and so forth. So you might want to try there. I'm not too hip on all the new trends there, but I don't really advocate the I don't know, those canvas Converse high tops, but they don't really do much for your foot. So the question was, what's the difference between a custom orthotic and a standard orthotic? And I'm thinking a standard orthotic is probably just an over-the-counter insert, more like a Superfeet, or Birkenstock does make an orthotic. Well, typically, I recommend the over-the-counter orthotic for people that are mildly to moderately pronated or have no significant biomechanical issues. If you're super flat-footed or super high-arched, I don't think that they're going to work. So I think, and plus, there's also a cost factor. And I find that the Superfeet is usually for $30 or $35 is a great deal, as opposed to, custom orthotics can be $300 to $500. So a lot of times I'll try one of those first, and then if I can solve the problem, great. And then the second question was about hill work and hill running and exacerbating plantar fasciitis. Well, I think what's happening is your plantar fascia is getting stretched excessively when you're going at these steeper inclines, and that's pretty common. It's just probably tearing a little bit. So I find that once you've had plantar fasciitis, you're more prone to injuring it again, and so that's why orthotics, I think, or Superfeet are really important, and you've got to be almost more careful about your shoes and replacing those, and even your regular shoes. You might not want to be just cruising around in Teva sandals all the time. I see so much of plantar fasciitis in the summertime. I can't tell you. So. Yes, yeah. Is it wise to continue orthotics after you've solved the problem? Yes, because again, I think that's the best long-term solution for preventing reoccurrence. So the question was, he lost a couple toenails, and some of them came back normal. Some of them are not coming back so much. A lot of times, what happens is when you traumatize the nail, again, you're risking infection from a fungus, and so the nail sometimes doesn't grow for another reason. You could have injured the nail bed, or what we call the nail matrix, where the cell comes from. So if you did that, and if you've injured it fairly severely, sometimes the nail is permanently injured, and so the nail will kind of just grow halfway or look kind of like a fungus, but it really isn't. So that could be the problem, or it could be just a slow-growing fungal issue. But it's either one of those two things. The question was, do I have any advice on preventing Achilles tendonitis and shin splints? Well, the first thing would be to get fitted in the appropriate running shoes. So that's key. And also replacing your shoes maybe more frequently than you think you need to. And then again, if you have a biomechanical problem, you're going to be a little bit more prone to getting those injuries. But I think also people tend to do things that they don't realize it's going to injure it. Like they might run the dish after maybe not doing it for a month or so, and certain flat shoes. I see a lot of this Achilles problems in women that wear flats or flip-flops in the summertime, and then they'll run hills, and then they'll get an injury. So I think not only your running shoes, but your other shoes you wear, you should be a little bit careful about. So the question was about ankle sprains and how can you get treatment to resume running hills and so forth. Ankles are, again, probably the most injured lower extremity joint in the body. And what happens is, again, the ligaments tend to get injured. And what happens when you strain your ankle is the ligaments stretch out. And if you don't allow them to heal in an appropriate position, they'll heal in a stretched out position. So you actually you'll lose stability. So how do you get stability back after it's been stretched out? Well, physical therapy is key, because you've got not only when you injure your ankle, you injure the ligaments, but you also can injure the receptors, what we call your mechanoreceptors, the proprioception, your feeling of stability. So those need to be rehabbed, as well as your ligaments and your tendons, to get you better balance and stability. So physical therapy can help you with a home program. They use these big rubber bands called TheraBands, and they can give you exercises in which to strengthen your peroneal tendons. Those are the big tendons that come behind the ankle, and they prevent your ankle from spraining, but they become weakened, and so those need to be built up. And then also the proprioception, the nerves around your ankle, need to be rehabbed as well, and they can do that with a balance board. And basically, you should not resume running unless you're able to stand on one leg and not drop down. You should be able to stand and almost close your eyes. That's kind of hard anyway, and then maybe bend your knee. But if you can stand and kind of bend your knee down or like this and not go over, then you know your proprioception and your strength is pretty decent to start running. I see so many people start running too soon after an injury, and they just keep injuring themselves, and then they get frustrated because it can be 6 months of pain and suffering, and if it was just treated more aggressively. So the question was, he finds that Teva sandals are the godsend for him, and he can walk and hike, but when he tries to wear closed shoes, he has problems. Well, if you have a big foot or a really wide, large foot, there could be just a whole array of issues there. Teva sandals tend to be a little bit better than just flip-flops, because they usually have a pretty good arch support. But there's a sandal that's even better than that I just found out on the web. It's called Bite, BITE.com, and or biteshoes.com, and they're great because you can actually fit an orthotic device in those. They actually make them for golfing too, and they're pretty amazing. And there's studies that these people have neuromas. A lot of people that have neuroma pain can't wear closed shoes, so they can only wear open-toed shoes, because every time they put a closed shoe on, their foot just starts to burn and ache. So you may have something like that. It's hard to tell without examining your foot and telling you what the problem is, but you might look into the Bite sandals. The question was, he has claw toes or hammer toes, and how can you treat those when you're running? That's tricky. When you have a hammer toe or a claw toe, your toe is bent kind of like this or like this. And what happens is you typically can get a blister or a corn that forms on the top because of rubbing. You can also get a really bad blister on the end of the toe because it's impacting the surface. So I haven't found a great thing for that, but there are some pretty decent pads that are called Silipose, and they have these really neat sleeves that are made out of silicone, and you can put them along your toe, and they can give you like a silicone gel pad without being too bulky. They also have these pads called Crest pads that can fit underneath the toes that help to kind of straighten them when you bear weight. I don't find that those are super comfortable into which to run in, but the Silipose, I think it's Silopos pads are pretty decent, and I use those a lot. So also, if you have pretty bad corns or callus formation, if you get that tissue debrided off, you'll be a lot more comfortable running. Do you get blisters when you run, or is it okay? that it hurts at the MP joint. That's because your metatarsal is actually plantar flex, because when you bend your toe back, you're going to get more of a load on the metatarsal. So you're at more risk for getting the metatarsal bursitis condition. So you need to be in a pretty padded shoe or a forefoot. So a metatarsal pad could also help, or an orthotic that could help balance your foot might be appropriate for that. So, the question was, is it okay to wear a running shoe as opposed to a walking shoe for brisk walking? And I'm glad you asked that question, because I advocate running shoes a lot more than walking shoes, because again, the running shoes can be kind of tailor-made for your foot type. If you have a pronated foot, you can be in a motion control or a stability shoe. If you're high arch, you can be in a cushion shoe. So they're a lot more leeway, and they're better fitting. I just think they're a better made shoe. I advocate running shoes for all my patients that walk, and people think I'm crazy, but I don't run, but they really, if you get an appropriate fitting running shoe, it's the best feeling shoe you can have, I think. The question was, what causes corns? Is the corn on the bottom of your foot or on the toe? Well, typically on the bottom of the foot, it's usually from a plantar flex metatarsal, or one of the bones is just carrying more of the load. So that's just basically a pressure point. So it's just getting more weight bearing. So those can be pretty tough to just solve. I think just having routine palliation or having it trimmed down every so often is probably one way to treat it. Sometimes a metatarsal pad or an orthotic can help that too, but I found that a lot of times these will keep recurring and they're frustrating, but if they're treated more often, then they might not really become that much of a disability. I have a recurring few calluses that I just have to whittle down every 6 months. And the question was, for chronic cases of plantar fasciitis, would you recommend hot or cold soaks? Well, one thing you could do is you could do both, what they call contrast baths. And so you have a bath of cold water and one of hot water, and you alternate from the cold to the hot. And that's just a common physical therapy modality that you treat inflammation and pain with. So for chronic cases, I find that just icing and deep tissue massage, I think, makes it feel better. So, but you may want to try the contrast baths. That might help a little bit. The question was, how do you make the decision to finally operate on a bone spur? Well, that depends on where it is. If it's in or around a joint that's causing a limitation of motion, then I think it's appropriate to have that treated, because in the men especially, I see this condition called hallux limitus, and basically the big toe joint starts to narrow and it starts to fuse, and so because of a collar of bone forms around it, and then it can't move because it rams into the bone. Well, thanks a lot. You guys had some great questions. Really appreciate that.